Now, it is my opportunity this morning to introduce Dr. Mark Gold, and it's been a pleasure knowing him for a number of years, and he has made so many amazing contributions to our field, as well as being a leader in academic departments. He is a translational researcher, author, and also an inventor, and best known for his pioneering work on our understanding brain systems that underlie the effects of opiate drugs. He has worked in this area of addiction for a substantial period of time. Those of you that come to many of these meetings also know he has made just an outstanding contribution to issues such as dieting and other issues of nutrition and its impact on us and how to do that. I really appreciated those presentations. His research career started, and he has this in our paragraph, in 1972. And he had been a prolific author of more than 1,000 academic texts, abstracts, articles, and chapters. Dr. Gold is also a multiple patent holder. Now, he has been a chair of the department, but he is currently lecturing at medical schools around the USA, including recent grand rounds at Yale University and the University of Cincinnati. I think I saw that you lectured at USC. You're a Trojan? Oh, okay.
Yes, but thank you.
Okay, I'm glad to hear that. He is an adjunct professor of psychiatry and at his alma mater of Washington U in St. Louis, and the chairman of the scientific advisory boards for River Mend Health. We're really fortunate to have him here lecturing for us this morning. Thank you very much.
Thank you. So thank you. I'm going to try to cover my career in translational research, or at least get up to 1985. That way there'll be a part two, and Dr. Nemiroff and the group will have to invite me back. I have no disclosures. It's actually my career that I'm talking about, and you don't have very many conflicts. Part of my work in this field has to do with what is addiction medicine, what kinds of challenges do we have in addiction medicine and psychiatry, and I worked for 10 years on this CASA, Columbia University Commission, and just last week the White House announced that the CASA findings were correct, that we have a drug epidemic, we have more patients who need treatment than we have providers, and the provider deficit is probably 300% of the active providers. So this is a really important area for people to embrace and get involved with. The other great thing about being a teacher is you have the chance to mentor people and work with them. So I met Nora when she was a psychiatry resident at NYU, just recently coming from Mexico. And she gave this talk at the APA last year, and part of her career can be understood.
Good afternoon. It's a pleasure, it's a honor, it's a privilege for me to be here with all of you and to celebrate all of the fellows. And I want to thank the APA and Dr. Sommergaard for giving me the opportunity to share this moment with you. I've devoted all of my life to study the effects of drugs in the human brain, to try to understand what is it that they do to our brains that in some people that are vulnerable can lead them to the complete loss of control with severe catastrophic consequences. But before I actually go into that and what I've learned, share with you, I want to share a personal story that perhaps can help you put it in perspective. As Dr. Sommergaard mentioned, I was born in Mexico City. And many, many years ago, when I was 5 or 6 years old, I remember having dinner in my family with my parents and my 3 sisters. And there was a man that came to deliver a telegram to my mother. I remember my mother crying after she read the telegram. And I had never seen my mother cry, and I wanted to console her. But she did not want us to see her cry, and she left the room and locked the door behind her. Next morning, my father will tell us that the father of my mother had died. And it was many, many years later, when I had gone through medical school, when I had completed my residency training in psychiatry, when I had already been working for many years using brain imaging to investigate what drugs do to our brains, how we become addicted. At the time when my mother was dying of cancer, and she called me and said, "Nora, I need to tell you something I've never spoken to you about." And she told me that my grandfather, her father, had been an alcoholic, and that in utter distress of not being able to control the strong urges to drink alcohol, he had killed himself.
So I think almost everyone will know someone who's had problems with drugs or alcohol, and it's a disease that's shrouded in shame and stigma, and even has influenced people's career choices. Nora is amazing for me, and we'll get into this. When I met her as a psychiatry resident, she was interested in addictions, and we had just published the paper on dopamine hypothesis, 1984. And she spent a lot of her early career doing the PET imaging that proved the dopamine hypothesis. So it's just amazing. So we'll review the history of addiction science as it relates to medication-assisted therapies, the impact of substance abuse, and go back and forth. So, when you have these early experiences like she did around the dinner table, I had an early experience in research and in studying something similar to what Dr. Goodman talked about in deep brain stimulation. We had animal models for self-administration where animals would hit a lever and give themselves an electric charge, and that gave them pleasure, just similar to how Dr. Goodman described it. And it turned out in rats, they would have individual differences in the amount of bar press and the amount of delivery of current they needed to get their own high. And there was a wide range of differences between animals. But one thing that was very clear early on was if you gave that animal experiences with drugs of abuse that raised their brain reward threshold, so that things that were pleasurable before were either not pleasurable or not as pleasurable after. And that kind of stuck with me as a young man when I met Dr. Goodman here at Yale. And so a lot of things in my work can be understood from that, just like a lot of things in Nora's work are understood by her early exposure. Some drug effects might be more like head trauma or TBI than like taking Prozac. That was a hypothesis that we had, and I got even the chance to do the cover of Biological Psychiatry and show what a bad artist I am, but I could come up with a figure that looked like a hammer, because this was an article where we compared a binge of methamphetamine to placebo to hitting a rat over the head with a hammer. And neuropathologists determined which of the three conditions it was, and they couldn't tell the difference between TBI, a brain injury, and a methamphetamine binge. So there are going to be things which change your brain's reward threshold that you could study by drug exposure, and there are other things that you just plain lose function. Anyone who works in impaired health professionals knows that neurocognitive testing and neurological testing are essential because the doctors are well compensated, but are they really fit for duty? Can they really do the work that they used to do? My work's also colored by specific mentors, and I'll go through them, but one of them that's an unheralded mentor is Bob Bick, who translated Sigmund Freud's cocaine papers and wrote the foreword and worked on cocaine and cocaine effects. And he defined what are the essential things to know in addiction. And these are the essential things. You need to know the drug itself. So for me to say cocaine, that says one thing, but you need to know then the route of administration. Is it coca leaf chewing, or is it cocaine hydrochloride sniffing? Is it cocaine hydrochloride injection? Is it cocaine sulfate smoking? All of those, route of administration, are the next thing. The dose. The dose is critical, and if we get to the dose for cannabis, you'll see that cannabis today is not the same as cannabis at Woodstock 1. Woodstock 1 cannabis was 0.5% THC. And you'll see newer THC can be 20+%, 40 joints at once. Duration, use of one time versus chronically. The user, the age of first use. The age of first use is often forgotten in history, but is really critical. The brain, when we have neurologists here, when's the brain fully gyrified, even from the surface? 21 to 25. So the idea that you would use a drug during puberty, the brain can easily get confused as to what's puberty and what is abnormal and should be forgotten. Age of first use. Age of first use could also go back into the womb. Mothers who smoke, their children have an abundance of nicotine receptors that are far greater than based on the genes assumed at conception. We've done a project where we overfed pregnant rats sugar, and the babies come out alcohol preferring, as if they're from Indiana University. 42nd generation of that. Genetic and epigenetic, second and third hand effect, personal characteristics. This is also ignored. And we talked a little bit about it in one of the breakouts yesterday. The lowest ranking monkey has the most proclivity, the easiest to addict. The highest ranking monkey in the social order has the most resistance to addiction. Comorbidities, depression and cigarette smoking, schizophrenia and cigarette smoking, bulimia and cocaine. And then there's the environment and price. When cocaine's $125 a gram in 1982, it's hard to use it every day. But I just got back from Cartagena with the drug czar and the head of the DEA, and in Cartagena they're now having a resurgence in cocaine growing, cocaine processing, and they've even a whole submarine fleet for the cartel to send submarines full of cocaine to the United States. So all that, and then stigma, like right now there's no one in this room smoking. But when I started in this field, there would be ashtrays, and half or more of the room would be smoking. The half that was smoking themselves, the other half was smoking their cigarettes, so both through second and third hand. So stigma is very important, availability, price, and then the overarching role of trauma, which seems to act like social rank and order, but trauma is a fertile breeding ground. If you remember all those things, it's easy to understand drug abuse. It's also easy to understand that there are different stages of addiction. There's the binge stage, which is just an acute exposure, and the changes that occur are limited to the changes of a drug over time. There's withdrawal, and that's complicated, and we made a lot of progress in understanding withdrawal. And then there's a kind of phase of preoccupation, which Dr. Goodman and I have often debated. It's interestingly similar from preoccupations in obsessive-compulsive disease. Please. So the secondhand smoke should never be...
Carelessness and cannabis triggered a house fire in San Diego. When firefighters put out the flames, they discovered an elaborate pot-growing operation there in the garage. Firefighters say some of those marijuana plants did burn. They also say one person was treated for smoke inhalation.
I inhaled so much smoke.
So, I mean, why is it that the doctors are always the last to understand things that everyone in our culture understands? Secondhand cannabis smoking is firsthand, but you didn't give your consent. If you're in a house where somebody's smoking methamphetamine, an apartment house, you're smoking methamphetamine against your will. The day before the hazmat crews show up on their hazmat gear, what's happening to people is very, very interesting. But as the United Nations last decree, clean air and water are essentials for healthy living, and we don't have clean air with drugs in the air. I'll do this quickly. If you'll just give me this real fast. This is from High Times, one of the journals I subscribe to. Lab-tested, stoner-approved.
I'm talking people about the same
28% THC.
They're running them numbers and the winners have a shame. The dice is loaded and the deck is stacked. The game itself will hold you back. Check out your mind and don't be blind to the number game.
Thanks.
What I say.
I can do this for a long time, but you get the point. Anything that you would have said about cannabis smoking in the 1960s has very little relevance today, because you couldn't show cocaine was addicting until, you remember my work for a whole decade on cocaine was addicting. The RDC of Finer said cocaine wasn't addicting. The first version of DSM said cocaine wasn't addicting. The second version of DSM-2 said cocaine wasn't addicting. The third version of DSM, the DSM-3, said cocaine wasn't addicting. And then everybody's board-reviewed textbook, the comprehensive textbook of psychiatry, said cocaine wasn't addicting till 1988. Why? Because you needed the dose and duration. High price, lack of access. You need dose plus duration. Then you needed a route that was easier to get you addicted, IV smoking rather than sniffing. But we did have the first report in the Lancet of intranasal cocaine addiction. We had the first report of crack smoking, and it's easy to forget. I can't go into the food work, but all that work was done at Princeton with Bart Hubble until he passed away. And I do have a reference of my 30 years. If you're interested, it's in physiology and behavior. Let's go to this one. So another impact that my mentor, Gene Redman, had was he had a monkey colony in St. Kitts.
This is the sleepy island of St. Kitts in the Caribbean. "300 years ago, vervet monkeys were brought here from West Africa along with slaves serving the rum industry. Escaped monkeys acquired a taste for alcohol by eating fermented sugarcane left in the fields. Today, they satisfy their thirst by raiding local bars. They have learned to be sneaky. Picking the right moment is everything.
You can't make this stuff up.
For years, the monkeys have been studied for insights into our own drinking habits. Just as we vary in our taste for alcohol, so do the monkeys. Some do anything for an alcoholic cocktail. But just as some people are teetotal, so are some monkeys. These reject alcohol in favor of soft drink.
Thanks. That's enough. So this stuck with me in that I worked with Gene and worked on locus coeruleus, and he was interested in Parkinson's disease. And these monkeys were an oddity, but they're interesting for a number of reasons. One is you could give them injectable naltrexone and show that the monkeys drinking cane alcohol in the wild would consume less if they had naltrexone on board. And so it was a really great proof in a natural model of the role of opiate antagonism in as a medication-assisted therapy, because they just drink less, didn't make them sick. The other thing this helped me with was our own work in sugar and understanding sugar as a reinforcer. And in yesterday's breakout, we said, well, animals will self-administer sugar, and they do have binges, and they do have evidence of sugar addiction, and you can produce sugar withdrawal by giving them naltrexone or naloxone. So it's all kinds of comes together. So much of my work in the field has been sitting by and cataloging the effects of drugs on the brain and behavior and physiological systems, but the number of people using drugs has increased so tremendously that it's startling. So we're in the midst of a heroin overdose epidemic. We're in the midst of a prescription opiate epidemic, and we're back to where my work started in the 70s, which was what's the neuroanatomy of opiate effects, what's withdrawal, how do you treat it, but how do you understand treatment? And what always follows an opiate epidemic is a cocaine epidemic, and that gets back to my cocaine work where we set up the first helplines and helped NIDA with that. And I mentioned already the Cartagena. So my career starts in '67. What a lucky guy. I get to go to Washington University in St. Louis. They have such a thing as independent study, which means I just can sit around and think. And for the people that know me, most of the time I'm just sitting around thinking. I mean, that's pretty much my career in translational research is thinking. At WashU, that meant I could go to the med school. And they actually had a psychiatry department that was interested in diagnosis and neurobiological treatment. And I got the chance to be mentored by John Feiner and understand that organized psychiatry at that time was ambivalent, to say the least, about drug abuse. They could make a diagnosis of drug intoxication without ever measuring the drug. So they could have, in the original iteration of the DSM, included blood alcohol or a breath alcohol for intoxication, but we didn't. They could have, and then there were debates about what was the core feature of addiction. And so in the early DSM, the core feature was a withdrawal syndrome so intense that you could die, or if you didn't die, you would throw up on the psychiatrist's shoes. So you had nausea, vomiting, and convulsions. It was alcohol or opiates. And so if you had a minor withdrawal syndrome or it was difficult to see, it was just affective, like cocaine, you're not addicted. And our cocaine work really helped change the diagnosis in the DSM so that the core feature was self-administration, continued compulsive use despite adverse consequences. In animal models, that's animals hitting a bar press, and we've shown, other people have shown that they'll do that once they have drug exposure, even in the presence of extreme pain, loss, and suffering, just like humans. So when you do interview a neurosurgeon who injected themselves before the operation with just tap water, you don't say, how could you do that? That's what addiction does. In animal models, if they're self-administering with a paw and you cut the paw off, they switch paws. If you cut both paws off, they go to the hind legs. And if you cut everything off, they use their head. They'll always hit the bar, despite great pain. So that's kind of where my career started. And also I went to Woodstock, so I learned a great deal. And at Woodstock, I was a volunteer in David Smith's Rock Doctors, helping people with drug overdoses. And so I had a lifelong work and friendship at the Haight-Ashbury Free Clinics, which helped my career a great deal. So, as I said, I worked in self-administration, ICSS. It's the gold standard, if you would, and helped me understand all drugs of abuse. I moved on from there to University of Florida. My wife was an undergraduate at that time and gave me a pay or play option, and I chose to move. There I got interested in memory. So my first work in that area was state dependency of memory, which I think is very useful in addiction, meaning if you learn something in one chemical state, it's coded with that state, and you have the maximum access if you're asked to retrieve it in the exact same state. So if you learn something under amphetamines, your maximal recall is about the same blood level of amphetamines. And that's, if you learn something in an amphetamine state and are asked to recall it in the straight state, it's not that you don't have it in your memory, you can't access it. So it's locked away in a trick of memory. And that explains why women remember childbirth the second and third time. That explains why depressed people how they feel as they cycle back into depression, and explains in addiction how a slip becomes a relapse so quickly. All those drug memories that you spend so much time in meetings and therapy encapsulating are still there, but you can't really access them until you're in the same chemical state again. And then you're that old person. And so state dependency of memory was a big part of my research career and got me from there to Yale, where a mentor introduced me to George Agajanian, and I started working with rats and moved up from rats to monkeys. At Florida, I did have the chance to work with Bob Cade, and I also got to give him his honorary degree. So as the university-wide professor, we got to give him his honorary degree from UF, and I learned a lot from him. But of course, the thing that I took home the most was that the first version of Gatorade didn't have sugar in it. And it helped my work in understanding sugar and self-administration. I worked some with Bill Lutke, who ended up starting the Brain Institute, and that began my work in sex and understanding where drugs might access the reinforcement system. Sex was really hard to study, and some of you who followed my career, everybody in research has successes and failures, and the failure here was I created a rat pornography video and tried to show it to rats to see the effects on the brain. And little did I know that rats don't care to watch pornography. So I moved on from there and graduated and moved to Yale, where the monkey lab was on the Sterling Library near the campus, but basically in the medical school rotunda where the dean was. We went in like a little elevator and up to the top floor. And my kids remember not being able to give the monkeys bananas because they were in research projects. But at Yale, it was like being an independent study again. I could work in 6 or 7 labs at once. And so I did neurosurgery in rats with George Agajanian, and I did the same in non-human primates with Moss and Redman, and worked with the cocaine group. And my whole career really comes from all of these mentors. So I sat in a lab and watched Jim Moss, one of the fathers of the catecholamine hypothesis of depression, stimulate the nucleus locus ceruleus and say, that's mania. And then ablate the nucleus locus ceruleus and say, that's depression. And that's a noradrenergic cell bundle. And I saw Gene Redman, who was the number 2 person in that lab, say to Jim Moss, no, that's not mania and depression, that's panic attacks and the absence of panic attacks. And so I was the lowest monkey in this monkey lab, and I said, both of my mentors are wrong. When they stimulate the locus ceruleus, it looks to me like a person who's in opiate withdrawal. They had piloerection, they had hypertension, they had tachycardia, they had hand-wringing. And then that became the basis for the paper on what opiate withdrawal is. And most people now wouldn't realize that it was a kind of a cool thing because we didn't even know what an opiate receptor was. And then from that came, you can reverse opiate withdrawal with morphine, and you could reverse it with clonidine. So I have a lot of interest in this whole area, thanks to these mentors, and it's a really puzzling area. As I said, here we are in a drug epidemic, and look at what happens. We have some effects like changes in brain self-administration, ICSH threshold, and then some changes. Drugs change the brain in ways that we can't change back. And you can see it in examples like this. That was a really successful young person who had looked like he would actually have a career in athletics, was a captain of athletic team, and moved on to become a joke. He's become the definition of what addiction is. Addiction is your boss says to you, that's a great job that you have, and we're paying you $58 million a year for, but while we're filming, you can't use drugs. And so it's the job or the drugs. And what do you choose? Drugs. So drugs produce a lot of effects, but always in withdrawal they produce dysphoria. If opiates cause pinpoint pupils, in withdrawal they cause dilated pupils. If opiates cause constipation, in withdrawal they cause diarrhea. If opiates cause euphoria, in withdrawal they cause dysphoria. And anhedonia, which was, by the way, the working title for Woody Allen's classic movie, Annie Hall. So I've worked a lot in this area and thinking about it. What comes first? I don't know that we'll ever really know, but it is very clear that psychiatrists have a major role to play in the evaluation and treatment of addictions because they're so commonly comorbid, and also it's so important. So here's a good case study.
He really wanted to prove to you that he is clean now.
Yes, good morning again, George. And he claims no drugs right now, but we did talk a lot about his past drug use. Charlie Sheen has never been more candid about it and makes no excuses for it. He also shared with us some of what really happened that night last month when he was rushed to the hospital after a drug-filled night with porn stars. Your anger and your hate, I think, is coming off as erratic to people.
Passion, my passion. It's all passion.
Your passion is coming off as erratic
to
people.
Well, you borrow my brain for 5 seconds and just be like, dude, can't handle it. Unplug this bastard. Yeah, because it fires in a way that is, I don't know, maybe not from this particular terrestrial realm.
I think some of those things that you're putting out there are making people think something's wrong with you.
That has nothing to do with me, really. I mean, they're entitled to, I suppose, interpret stuff as they must. What are you a doctor of?
Some are saying that you're bipolar.
Wow, what does that mean?
I guess that, you're on two ends of the spectrum.
Wow. And then what? What's the cure? Medicine? Make me like them? Not going to happen. I'm bi-winning. I win here and I win there. Now what? If I'm bipolar, aren't there moments where a guy crashes in the corner oh my God, it's all my mom's fault? Shut up. Shut up. Stop. Move forward.
Have you had any celebrities reach out to you?
So he plays an interesting role in the West Coast in supporting the idea that detox is treatment. So a part of what treatment should be is detox. But he didn't read our papers in 1978 through 82 where detox isn't treatment, it's detox. Detox isn't treatment at all. We successfully detoxed 100, Herb Kleber and I, 100 opiate addicts and followed them for 1 year with no other treatment because no treatment was available at Yale at that time. And 99 relapsed and 1 had a religious conversion. So we dispute that. But we do have an importance of residual deficits and dysfunction. And thinking back to the cover of Biological Psychiatry, some drug effects are like traumatic brain injuries and will take a long time to heal. Other drug effects are subtle. They change the brain's reward threshold and make depression more likely. He's been counseling celebrities, and some of them have, some of the relapses are to be expected, because if you just look at the neuroanatomy of withdrawal is distinct and separate from the neuroanatomy of I want this drug, I need this drug, I like this drug, the attachment to drugs. And in animal models, by the way, if you lesion the nucleus locus coeruleus, you don't have any effect on drug self-administration. It is true that withdrawal adds to the incentive to use, but it's not true that eliminating withdrawal eliminates taking drugs. So we did this locus coeruleus and moved on from there, and we found a number of things. Detox, we could detox people. We invented the first non-addicting treatment for opiate withdrawal, which was clonidine. And just so you know how interesting this was at the time, in 1978, the World Health Organization defined an opiate as any drug that reversed opiate withdrawal. So then clonidine, which was Catapress, an antihypertensive, was afraid that they'd be reclassified as an opiate. But all that was wrong. We learned that detox doesn't prevent you from relapsing. But then we learned, well, gee, if you're going to relapse, we might put you on an experimental drug. At that time, came in a liquid, naltrexone, which was made by Endo Labs, which was a long-acting Narcan. And then we found we could, if you were addicted to opiates and we gave you an injection of Narcan, if we gave you one injection, another injection, another injection, another injection, with each repeat injection, you had less and less withdrawal, so we could rapid detox you and put you on naltrexone because of that kind of brain trick. Then we that was with infusions. And this is still the main, I put this up for you, Wayne. Wayne and I knew each other at this time. And you see, like, I did all this research on a slide. But nevertheless, abstinence has been the focus of the DSM. We separated withdrawal from treatment with clonidine, but we saw all the depression, relapse, and problems. And we said, well, detox works, but it doesn't prevent relapse, so we'll use naltrexone. Now that is the first use of long-acting opiate antagonists, and the naltrexone was actually approved on the basis of Chuck O'Brien and our studies of one patient population, and that was impaired health professionals. Really, the first approval was as an orphan drug because we couldn't get other people to take it. So we detoxed physicians and business executives with clonidine and put them on naltrexone, but they had job jeopardy, they had to take it. And that was a really cool idea, and we were very happy about that. So we reported that with Arnie Washington. I'm not going to be able to do this because I don't want to run out of time, but believe me, the number of physicians who have drug and alcohol problems is increased and not decreased, and the number with depression has increased, and the number who are aging and have fitness for duty issues. These are all very important areas. I mentioned quickly naloxone because you've heard a lot about the use of naloxone in kits and availability for emergency personnel. We use naltrexone in the early 70s, and you have to keep track of the person, and it's useful to remember that resuscitating them is important, but it doesn't treat them. And there are now studies in emergency centers of people who've come back repeated times for naloxone. We use it in Yale. We couldn't admit patients to Yale New Haven, but we could treat them in the emergency rooms. And the treater was Jack Fishman, who was a Sloan Kettering cancer researcher who invented this use, and then naloxone was modified to become naltrexone. Quite an amazing story, and anyone who's interested can email me. I I looked into this in a popular book I was writing at the time. And so naltrexone was an orphan drug. Nobody really used it. People thought that it was great because you could give it orally. It was long-acting, but again, we couldn't get patients to take it except people who were in long-term treatment. And so I used naltrexone and reported in the late 70s. Hardly anyone got very excited about it. The government supported this study, which was a multi-center study, and we were one of the centers at Yale, and then we failed in proving that it changed anything in the natural history of the disease or even in short-term 6-month outcomes. But naltrexone was approved on the basis of the use in physician addicts and special populations. So the first kind of medically assisted treatments were medication maintenance, like methadone. The first medication treatments were treatments in emergency settings with naloxone. We nuanced that with clonidine as an opiate surrogate, treatment of withdrawal, induction onto naltrexone, and you see a lot of that now. I don't have time for that, but the moral of the story is this was news in 1981 because it was the first truly bench-to-bedside addiction pharmacological research that led to new treatment. And from there, we moved on to do other things like think about relapse and brain centers and think about Mark Twain, and who said it all, which is that, of course, detox isn't a treatment. Think about everybody who's tried to smoke. After every opiate epidemic has been a cocaine epidemic in our country, and David Musto and Bob Bick helped me understand that. Cocaine was safe, was the cover of Time, and I'm lucky in that Bob Roth taught me how to measure cocaine in urine and measure cocaine in blood, and we ended up doing a lot of testing for professional sports as a result of that. Cocaine was misunderstood as increasing dopamine in synapses, and Goodman and Gilman at the time said cocaine increased dopamine and other neurotransmitters. And so this was kind of a mind experiment for me where I just wrote a hypothesis paper with Charlie Dacus in '84, said, well, that's nice, but people just don't use it once. What if they used it every day? Would they use up more dopamine than they could make? And we then said they could, and then that was proven by Nora Volkoff, who did that with PET imaging. I'll show you really quickly that death and disability occur just like we describe. Addiction is chronic, lifelong, relapsing, and often fatal, and it's very hard to get people into treatment. And it's hard to get almost anyone into treatment, but definitely it's hard to get celebrities into treatment. That should be understood. But think about all the enabling that would go on if you have a hole in your nose or missing 11 front teeth and you're able to perform and appear publicly. It's a tragedy that occurs, but is easily predicted by animal experiments. So our work helped us understand drug withdrawal through the noradrenergic locus coeruleus and how we get addicted through the dopamine hypothesis and the work with cocaine and Musto's history of drug epidemics in the United States. But there's, again, back to our original axioms, cocaine is cocaine is cocaine. So on my recent trip to Cartagena, many of the people compared cocaine tea to tea, coca leaf chewing to Coca-Cola, and distinguished that from the use intranasally as cocaine hydrochloride, the use intravenously, and the use by smoking. And that's by causing this rapid peak in cocaine, it makes addiction much more likely than taking cocaine as a patent medicine or as a wine or any other way. I told you I'd get up to the 80s. We had the era of the speedball, where injection of opiates with cocaine, the whole Saturday Night Live thing, and some of you remembered we invented the first hotline and interviewed thousands of cocaine addicts who said, I have cocaine addiction, but my doctor says it's not in the DSM, that I have cocaine-related panic attacks, I have cocaine-related heart attack, and that led to all this work on dopamine depletion and dopamine theory and the role of the dopamine system in drug self-administration, anhedonia, and relapse. So I think you'll see how the treatments today are working around these areas and how detox is limited. Detox and relapse prevention has been the focus of attention. Maintenance has been an alternative treatment with psychotherapies and supportive therapies and behavior change, and that underlying all of the work is something that addiction medicine often forgets and psychiatry doesn't, is comorbidity and the fact that drugs change the brain, and some of the changes are not easily reversible. Thank you very much. Someone had the first. I had a patent slide, which is not here, but the first patent on my patent slide was the use of clonidine. So that was a really nice core patent. And then the third patent on the list was the dopamine hypothesis and the use of dopamine augmentation strategies in reversing psychostimulant abstinence. Clonidine has had a use as an analgesic potentiator in neonatal opiate withdrawal and in opiate withdrawal, and is used today. And then some of the other things are, someone asked me about anesthesiologists. Some of the others are, we've worked on how to measure, we can measure naltrexone in breath, by the way. So that's a patent. So part of the reason to give injectable naltrexone is that you knew that someone was taking it, but we're working on a breath test so that you could give naltrexone for 10 cents and monitor it from an iPhone. So, I mean, there are kind of a wide range of things. I measured secondhand drugs in an ambient room. That work has led to our recent work in Afghanistan, showing that children, in a 5-year study supported by the State Department, that children growing up in Afghanistan had drugs in the air on the hut floors, and they were being absorbed in infants, making it difficult for them to learn, regardless of what the State Department interventions were. When the father smokes opium and the mother is at the father's side and the baby's on the breast, it's getting opiates from the air on the ground, in the skin, and unable to process information. So I had a patent that allowed us to figure out how to do that.